For the last talk of this session, I have the privilege of honoring or introducing. Can honor you too. Happy to honor you. In the privilege of introducing Dave Greenwald. Dave is our director of clinical gastroenterology and endoscopy, and has really impacted the quality of our unit, the efficiency in our unit, and really helped us expand the capabilities of what we're able to do. So he is going to give us an update in quality in endoscopy. Dave.
Thanks, Chris. Thanks, Chris, and congrats, as I said earlier this morning, to Chris on putting together like an outstanding course. So really great job. And I have to congratulate Steve on the logo and the little needle. I hope you all noticed that, the needle in the haystack. If you didn't, there'll be a remedial course later, but we'll get going. So my task for this afternoon was to just touch on a couple of topics in quality and endoscopy. Also, kind of late in the afternoon, we've done a lot of stuff already today, so we'll try to have a little bit of fun also. Chris has done a pretty cool job. He's a pretty cool guy. Just moved to a new apartment. He's got, a convertible. And Chris, is always looking for a high quality experience. So Chris is out on this sunny day having a wonderful high quality day. But it's not going to work out for him because there's this truck and the outhouses and the overpass. And yeah, that's about right. So you're always aiming for a high quality experience. You should always avoid low quality experiences. Like that's a low quality experience, so painful too. Anyway, and I want to thank Irving Pike, who shared some of the information that I'm going to present to you today. Irving's been a collaborator in GI QuIC, as president of GI QuIC, and has really sort of moved the needle forward on quality in colonoscopy in particular over the past 10 years. So, when did anybody start caring about quality? We know that for example, there's been a great movement in this country toward doing colonoscopy. Sid Winnower said, the best test that gets done is the right one for colon cancer screening, and it's sort of morphed now into the best test that gets done with high quality. And the impetus for a lot of this started about 15 or 17 years ago with the Institute of Medicine publishing something called the Transparency of Clinical Quality. It led to some publications by the AGA in 2005 and then a joint task force of the ACG and the ASG in 2005 that ultimately put out in 2006 quality indicators. So although we talk about this a lot now, the sort of codification of all this is really only 10 years old. So in 2006, there were quality indicator documents put out for GI endoscopy that had to do with general principles, and then one for each of the sort of subspecialties, if you will, so upper endoscopy, colonoscopy, ERCP, and so forth, simultaneously published in the two journals. Those guidelines or quality indicator documents have actually been updated in 2011. At the same time that those articles were being published in 2006, the presidents of the two societies that sponsored those documents put out sort of a joint statement, which really summed up by saying, when we address the issue of performance measures for endoscopy, it becomes clear that we have no reliable way to distinguish a high-quality endoscopic procedure done by a trained endoscopist from a procedure performed by an inadequately trained provider. And they argued for objective, practical ways to grade our performance. Again, it's only 10 years ago. So, and that led to a real an attempt to make something that would be practical and easy to objectively define whether endoscopists, colonoscopists, ERCPists, and gastroenterologists in general were doing a high-quality job. At the same time, there was a new focus on quality from the payer perspective, and there were physician quality reporting measurements that were designed by CMS and by other government agencies to try to really sort of identify high-quality performers, and then find a way to either pay bonuses or put penalties in for lower quality performers. The NQF, this was a whole alphabet soup, but the NQF as a National Quality Forum was formed and began vetting measures. And lots of other people started making rules and regulations for gastroenterologists, and that wasn't necessarily a positive development. Gastroenterologists came together, particularly through the ACG and ASG task force, and said we could do this ourselves and we could do it quite well. And it led to the GI societies essentially putting out guidelines and quality measures that are still being used today. So that was the sort of concept in 2006. And the question really was, could we develop an electronic registry that was capable of generating reports for doctors, for gastroenterologists, that were based on the quality indicators that came out of these 2006 publications? And the answer was absolutely yes. Second important point was that it had to involve no additional work or minimal additional work because the data was already there at that point, because endoscopic software reporting systems were coming into wider and wider use and are now basically ubiquitous in this country. So the information for abstracting quality data from those software reporting systems was there. It just had to be harnessed, and that was done. And could doing that replace this sort of arduous, really handwritten PQRS system that was in place? And so an advisory committee was formed and ultimately led to sort of a way of mining data. And basically all of this is showing you that you could take data from individual endoscopic procedures, so all of the things that we're now much more familiar with, you could extract them from those endoscopic reports basically, put them into some sort of data warehousing system, extract the data from them, recompile them, if you will, into reports, and then set out reports that would allow you to understand performance on any of these different quality indicators that were suggested in those documents, or any other quality indicators that you might be interested in. So this is some of the data from those very original benchmarking reports, or not benchmarking, but quality reports in 2006. And they were initially looking at things that they thought were going to be important. So cecal intubation rate was postulated as an important quality indicator in colonoscopy. Sounds fairly obvious, but when you actually looked at information from a wide range of providers, cecal intubation rates varied quite widely. So these were initial studies looking to establish what the benchmark would actually be, came up with a target of 95%. And the important thing here was that there was some proof or some way that you could actually verify that the cecum was reached. So the idea in this initial pilot project was not only to compile data, but to have it so that it could be verified and looked at in an auditable way. Same thing with adenoma detection rates. This is actually data from the pilot study from 10 years ago. And you see adenoma detection rate at that point in the pilot study, the overall adenoma detection rate was about 26%, higher adenoma detection rate in men as compared to women. And these were in screening exams in people who were over the age of 50 with no documented high-risk features. A couple of terms that are important are benchmarking. So benchmarking has become an important term because it's the way that when we're talking about in endoscopy, for example, that we can compare a person or a group or a city or whatever you want's performance to some other group, let's say a national average. So it allows people to be compared, and it also then allows opportunities for improvement. So you can say that if the national average adenoma detection rate is 25% as a goal, and your adenoma detection rate is below that, there are opportunities for improvement. And if you're higher, then you are going to be less likely to need some sort of improvement program. It also allows individuals, it allows hospital systems, it allows cities. In New York, for example, we got together and looked at adenoma detection rates through the whole city. An opportunity to establish best practices and ways of actually improving performance. So a lot of this also is tied into something called the Hawthorne effect. So how many of you are familiar with the Hawthorne effect? Not too many. It's interesting. Okay, so Hawthorne effect's a really interesting effect, and basically it comes out of this picture, which is an electrical plant, and a study that was done in the 1920s. And the postulate, and the plant was called the Hawthorne plant, and it was a General Electric plant, and they were actually looking, somebody there was interested in looking at the efficiency of workers, and the postulate was that if you changed the lighting in the plant, people would work more productively. And the hypothesis was that if you made the lights brighter, people would work more productively. And so they did that experiment, and they actually turned the lights up, and they measured productivity, and it went up. And then they did the opposite experiment, which was they made the lights dimmer, to show that that would make people work less well. And it turned out when they made the lights dimmer, but still told people that they were doing the experiment, they were also more productive. So the Hawthorne effect is basically describing the fact that when you know you're being watched or you know you're part of an experiment, you do better. And this is definitely the case in GI endoscopy for sure. So again, this is the definition of the Hawthorne effect, is the tendency of some people to work harder and perform better when they know they're participating in an experiment. So you could argue that the quality and endoscopy movement is a grand experiment that we're all playing a part in, but we're all doing better because we actually know now that we're actually being looked at all the time. And there are lots of examples of this. A great example comes from Indiana University, where they put cameras into endoscopic rooms and told people they were being observed, and their performance improved pretty dramatically in almost every measure. Okay, so that led to the formation of QuIC. So QuIC is a joint venture that was founded by the ACG and the ASG. It's an independent organization that's only been in operation for about 7 years now, but it is a web-based electronic registry. And the vision for QuIC was to really set the standard for measuring and improving the quality of digestive health care. And it did it through defining some metrics, measuring performance, analyzing and creating statistics that could be compared, looking all the time toward continuous improvement. And ultimately, if you think about this, which is now an enormous database, the implications for research, education, training are phenomenal, actually. So towards that goal of eliminating the arduous PQRS process and fulfilling requirements that physicians have for reporting quality, which has become increasingly important, and you'll hear more about, not for today, but for another day, about MACRA and MIPS and all sorts of things like that. QuIC in 2014 and 15, and actually also in 2016, became something called a Qualified Clinical Data Registry. So it allows gastroenterologists the ability to report automatically on 13 measures and get credit for that in lieu of doing something handwritten for PQRS. And for people in hospital systems, this is actually done, and it satisfies requirements for reporting. So QuIC has grown tremendously. And if you look at 2011 down here, and now you look at, this is middle of 2016, so I have data that goes further than that, but this is the one I chose to show. You can see that there are about 4,000 GI physicians participating in QuIC. So anybody have an idea how many GI physicians are on the country? Stone silence. About 13,000. So this is about a third of the physicians, gastroenterologists in the United States, are now participating in QuIC. And much like getting the 80% by 2018 goal reached and getting those additional people screened, the interest now is how to get the other 8,000 gastroenterologists involved in this. And there are a variety of ways that might happen. Those 4,000 physicians belong to group practices or linked systems, so it now represents about 500 systems. And if you look at the procedures are actually fairly staggering. So the first 100,000 cases showed by September 2011, we got to 1 million in November of 2014, we got to 2 million in September of 2015, we got to 3 million in April of 2016, and by December of 2016, we got to 4 million. So, you know, this is an enormous, enormous registry that is unique in the world. Actually, this is the largest GI registry in the world right now. There are also upper endoscopy measures that are available, now over 500,000 of those in the registry. So for quality indicators for colonoscopy, as I said, in 2015, the 2006 quality documents were updated. And one of the notable changes was they went from a laundry list of quality indicators to ones that were considered priority quality indicators. So the three for colonoscopy are adenoma detection rate, use of recommended screening and surveillance intervals, and cecal intubation rate, including photo documentation. And it's that photo documentation that makes this auditable, if you will. In that QCDR nomination in 2016, for QuIC, there are 13 measures actually that are accepted. They're listed here, but it's adenoma detection rate, adequacy of bowel prep, photo documentation of the cecum in a variety of settings, incidence of perforation, appropriate follow-up interval for normal colonoscopy in both average risk screening patients and then in patients who've been found to have polyps, documentation of a history and physical, appropriate indication, and the other measures have to do with whether a repeat screening colonoscopy is recommended within 1 year when an inadequate bowel prep has come across, and a couple of upper endoscopy measures, including H. pylori status and appropriate management of anticoagulation in the peri-procedural period, which is pretty much what Steve was talking about a few minutes ago. So these are data from QuIC, and you can use this very powerfully to look at your own institution, your own practice, your own city, and compare it to national levels. And what you see, if I randomly picked one site, but more important is the blue bars. And the blue bars are the entire study. And if you look at, and in this case, adenoma detection rates between 2013 and 2015 across the whole population of people who are participating in GI QuIC, adenoma detection rates going up. Cecal intubation rates, similarly, 2013, 2014, 2015, going up. A little bit of that represents improved use of software and people understanding how to make those boxes correct and then get credit for what they did. But some of it is clearly awareness, so people are doing better and this registry is working. Another important concept in quality has to do with whether people who are doing a good job at adenoma detection rate, does that translate into a decreased rate of interval cancers? So the problem here is that if we believe that colonoscopy, for example, is good in screening for colon cancer, then how do we explain interval cancers, which would be defined as a cancer that occurs within 3 years of a supposedly negative colonoscopy? And we know there's a high miss rate in colonoscopy, and does that have any correlation with adenoma detection rate? So this is sort of a famous article now from a couple years ago by Corley, and he basically separated people out into quintiles based on their adenoma detection rate. And all you really need to look at is low adenoma detectors. So this would be somebody who had an adenoma detection rate between 7 and 19%. And we'll use that as the reference. And then what we want to show is how much better those who are better adenoma detectors are at preventing their patients from developing interval cancers. And if we go to adenoma detection rates of 28 to 33%, the risk of having one of those interval cancers drops by 30%. And if you have an even higher adenoma detection rate, so let's say greater than 33%, that risk drops by 48%. So this is really important stuff. Does GI QuIC have any sort of match to this? And it turns out it does. So I will skip to the great minimum of 400 screening procedures. But again, what you notice in this graph is all of those same Corley quintile ranges here. And then you look at how likely people are to fall into those quintiles. And I will show you the minimum 400 screening procedures. So for example, if you group what you would consider to be the high adenoma detectors, so if we use 25% as our benchmark, and we take everybody in quintile 3, 4, and 5 and above, and we add them up, we had 13%, 20%, 42%, and 7%. This means that most of the people who are participating in GI QuIC are actually falling into this high adenoma detection rate group. And if you believe the Corley quintiles, then that's good to be in that high adenoma detection rate group. So this stuff really, again, matters. These priority quality indicators, again, this shows you between 2011 and 2015 an improvement in cecal intubation rates, and it shows, again, an improvement in adenoma detection rates. And it can be split out. The data is very powerful. It can be split out in terms of the blue bars are screening exams, the orange bars are diagnostic, and the green are surveillance exams, where you'd expect the adenoma detection rate to be higher because those patients have already been found to have polyps in the past. The other thing that's very, very much in vogue right now is looking at screening and surveillance intervals and whether they're being followed appropriately. This is really an economic issue about utilization of resources. And there's a lot of information that's coming out now about proper use of colonoscopy as a tool after a normal exam. So these are data from GI QuIC again, looking at what's recommended after a normal screening exam. And so the recommendation by the guidelines committees have been 10-year intervals, and you can see that's followed about 3/4 of the time, which means about 1/4 of the time that's not being recommended. So, as they say in Europe, mind the gap. Same thing for follow-up recommendations in patients who have small numbers or small adenomas found at colonoscopy. So the recommendations from the guidelines there would be to do a screening exam at 5 years. And you see that's what's coming up about half the time now, with a smattering of all sorts of other stuff around. Again, mind that gap. This is data from one practice in Texas, so just an isolated thing, not controlled for anything. But what you see here is adenoma detection rates in 2009, and then adenoma detection rates in 2015, and uniformly across the board in that practice, it went up. And this is actually the rate of colon cancer surgery in that same area in Texas. And you just notice that the incidence has gone down. The suggestion is that there's something that's going on with colon cancer screening that's leading to less colon cancer surgery, and perhaps it's better exams and better high quality exams. So the question that was asked really was, can a registry improve the quality of colonoscopy and reduce the incidence of colon cancer? And it does appear to be true. I'm a big proponent of GI QuIC. The incidence of colon cancer in this country and in this city has actually gone down pretty dramatically over the past 10 years. Mortality from colon cancer is declining. Lots of things have changed. There's clearly a focus on screening, but there's clearly a focus on quality. More education about this, better technology, better endoscopes, better ways of looking at things, better tools for taking out polyps. We've been benchmarking now for 6 years, steadily increased the mean ADR, and we've improved the quality of colonoscopy. So this stuff really matters, and it's really making a difference. And then, I'd finish up by saying there are lots of opportunities here. So we can look at everybody's individual data or groups of data and make real interventions. The QuIC program is a program by Mike Wallace at the Mayo Clinic in Jacksonville, and it really was, it's a programmatic way to look at low adenoma detectors and improve their ability to detect adenomas. It's sort of a video training or an individual training module, followed by just continued sort of watchful observance of what they're doing. Corley's top performing groups, is that the limit, or can we do even better? And as I said, there's a database now of 4 million colonoscopies. So for those of you who are into research or thinking about public health questions, this is the largest database that exists right now in the world in colon cancer screening and colonoscopy quality. So I will leave it then that quality matters in everything, like I started. So if you're into riding, you got to have all the wheels. If you're into paving streets in New York, that's a bad quality paving job. If you're in jail and you want to dig yourself out of jail, you got to be sure you know where you're going, because you got to do it well. It's another outhouse problem. This whole day has been looking about endoscopy, so this is really all about how we look into the GI tract. So I leave you with one other thing, which is this is how this guy looked into the GI tract. This is called direct colonoscopy, for those of you who are wondering. And that is my story, and I'm sticking to it.